Good morning, good afternoon, good evening, everyone, and thank you very much for joining us for our webinar on a review of the evidence for men's engagement in child health and immunization. We're going to briefly start with some guidance on the simultaneous interpretation and how to view the slides on the various languages. And before we do that, I do want to just introduce myself. My name is Elizabeth Arlotti Parrish. I'm a Senior Technical Advisor for Gender at Jhpiego. And we have with us Myra Betron, our Director for Gender at Jhpiego, and Jean Monroe, the Senior Manager for Gender at Gavi. Next. So we will be interpreting this webinar in English, French, and Portuguese. If you would like to listen in French or Portuguese, the instructions are here. You can go to the interpretation globe at the bottom of your screen, and you'll see the options for the different languages. And just select the language that you like, and you'll begin to hear the interpretation. Please note that if you do not speak all three languages, if you do want to listen just in English, you will need to join the English room, as there may be some additional languages coming out in the main room. We also have the option to view the slides in English, French, and Portuguese. This option only works if you're on the desktop version of Zoom. So if you're in the web version, you may not have this option. So what you can do, go to the green bar at the top of the screen, and you'll see View Options. When you look at View Options and click on that, you'll see three different options. You'll see my name, Elizabeth Arlotti Parrish, English, Myra Betron, Portuguese, and Aleph Tesfalice in French. So again, just select the slides that you're interested in viewing, and you'll be able to see the slides in your preferred language. And with that, I'll turn it over to Jean for a brief introduction.
Thank you very much, Elizabeth. And welcome everybody to this really exciting webinar. So I'll share a bit of background of what we're doing. So as you know, Gavi's mission is to ensure that all children have access to immunization services. And we know that one of the reasons why children are not vaccinated is due to gender-related barriers that hamper parents' and guardians' ability to access immunization as well as other services. Some of these types of barriers can be women's ability to travel unaccompanied, the ability to use family funds to cover transport costs to the health clinic, the exceptionally enormous workload of women both in the home and outside, and access to informed information regarding vaccines. We're learning from other health and social sectors that working with men or fathers can be an effective approach to address these types of barriers and also to improve equity between women and men. We've therefore partnered with Jhpiego and the governments of Togo and Pakistan to undertake implementation research to better understand what are the range of activities that are called engaging men and how effective are they in the immunization space as well as other areas. So with this understanding, we'll then design initiatives in Togo and Pakistan to test the different approaches and assess their effectiveness. We'll then be able to support and scale up these approaches. This research is part of the Gavi Alliance's learning agenda on gender responsive and transformative programming. I'm really excited about this webinar because we have Jhpiego has now brought together all the evidence that is out there on men's engagement, and we'll be sharing that with us today. Thank you very much, and I'll hand it back over to you, Elizabeth.
Thank you, Jean. Next slide. So as we get started, just wanted to put us all on the same page with some key terms and definitions. So first of all, we are talking about gender, not talking about sex, the biological differences between women and men, but in fact, we're talking about the socially constructed norms around being a woman or a man that influences behaviors, including health behaviors. We're also going to be talking a lot about programs that are gender transformative. You can see the long definition here, but in essence, a gender transformative intervention is one that seeks to, as the name implies, transform gender norms with the goal of creating a more equal society. And our main focus is going to be looking at interventions for men's engagement. And we have a formal definition of men's engagement, which is a programmatic approach that involves men and boys as clients, as partners, and as agents of change to improve health outcomes and also create more equitable results. Next. This evidence review was conducted as part of a men's engagement in immunization program funded by Gavi and implemented by Jhpiego in collaboration with ministries of health and other stakeholders. We have some global activities such as this evidence review, and we'll be conducting implementation research in Pakistan and Togo. We began the project in February and will be continuing until December 2024. Next. Here you can see our project objectives. We're currently in project objective number 1, which is gathering the current evidence on engaging men as caregivers to help us understand how these activities of engaging men can expand immunization coverage. The results of this evidence review are going to inform the next few project objectives as we work together with our colleagues in Pakistan and Togo to develop a monitoring, evaluation, and learning framework, theory of change, create operations research activities to both improve men's role in caregiving, to increase immunization uptake, and think about how these interventions can strengthen gender equitable attitudes and roles. Next. Before we get into the work that we've done in this evidence review, it's important to note that there is a strong body of evidence on the benefits of men's engagements within maternal and newborn health and nutrition, particularly gender-transformative men's engagement for both health and gender equity outcomes. In 2020, Jhpiego led an evidence review looking at this issue and found that there are many effective men's engagement interventions that can improve health outcomes. And these include gender-transformative approaches, as seen here, such as changing men's attitudes, shifting community norms, facilitating couples communication, and building men's knowledge and support to support their partners' positive health behaviors. And these approaches can take the form of gender-transformative men's group education, couples counseling, and other interventions to increase support by men as partners for reproductive, maternal, neonatal, child, adolescent health behaviors. There are also many promising approaches that have not yet been peer-reviewed, but show a lot of potential success in improving health outcomes and increasing gender equality. Next. Including parenting education programs, gender-transformative couples education around RMNCH, couples communication relationship skills building, and community dialogues to shift harmful gender norms and prevent intimate partner violence, as well as more fun edutainment to shift gender norms. Next. Our evidence review centered around 3 guiding questions. First, we wanted to understand what current challenges and opportunities exist for engaging men in caregiving and addressing their concerns related to immunization and strengthening their role in influencing immunization uptake. We also wanted to see what the effective and promising men's engagement interventions that we can use to integrate into child health and immunization programs. Finally, we were looking at the effective and promising gender-transformative interventions that have the potential to be integrated into child health programs. It's important to note that these second and third questions are slightly different. We know that we can engage men in ways that may not be gender transformative, that reinforce their current roles as decision makers or their current roles in household caregiving. But we really wanted to look at both of these options, men's engagement interventions in general, and particularly gender transformative interventions. Next. Our evidence review had various components. First, we conducted a literature review. And you'll see in the titles here, the numbers in the parentheses are the questions that these components sought to answer. So our literature review sought to respond to the second and third questions of our evidence review. We had 20 peer-reviewed publications on child health and immunization, 8 studies in 5 documents from the gray literature, and studies were drawn from 19 low and middle income countries. We also had an online survey of global experts, which responded to all 3 learning questions. We conducted key informant interviews, again, to respond to all 3 learning questions. We conducted 15 interviews with global and regional experts, 3 interviews with experts in Togo, and 3 experts in Pakistan. And then we didn't want to leave out the people closest to the issue. So in addition to our expert consultations, we also conducted focus group discussions with caregivers, both women and men in our 2 focus countries, as well as immunization health providers in Togo and Pakistan. Next. Here you can see the Prisma diagram for the literature review. The inclusion and exclusion criteria were based on conversations with subject matter experts in gender, child health, and immunization fields. We selected the inclusion criteria included studies from low and middle income countries published between 2010 and 2023 in English or French, in which men were engaged as active participants along with partners as agents of change for promoting child health or immunization. Next. We also conducted this evidence review using some guiding frameworks. The first guiding framework was the socio-ecological model. As we know, health behaviors are determined by factors at all levels of society: the individual, interpersonal, community, health system, and political environment. So all of these factors can influence caregivers' behaviors, both women's and men's. And as you'll see when we get into the results, we've organized the results along the different levels of the social ecological model. Next. We also wanted to ensure that we had a strong guiding framework for what we mean by men's engagement. And so we actually used 2 different frameworks. The first I mentioned earlier, the Interagency Gender Working Group's definition of men's engagement, which looks at men as clients, as partners, and as agents of change. And generally, when we're looking at men's engagement in health, we tend to focus on the second idea of men as partners. And so we used a second framework, which delved a bit deeper into what it means to look at men as partners. And so we relied on Gal et al.'s recent Delphi study on their global framework for assessing male involvement in maternal health. And so it looks at 5 unique roles of men as partners: decision-making, practical support, communication, physical support, and emotional support. When we talk about physical support, we talk about men accompanying their partners to health services, or in the case of immunization, taking their children on their own. Practical support, let's get back there. Practical support includes providing finances, providing support with household tasks, anything that can make the female caregiver's job easier. Emotional support is just what it sounds like in terms of helping to deal with the emotional consequences or emotional constraints regarding health, decision-making about whether or not to take children to services, and then improve communication. So we looked at how various interventions can impact the relationship between women and men and with the children across these 5 dimensions. Next. As we look at men's engagement interventions, it's also important to note that we need to be doing no harm. Even though we know that men's engagement has great potential for increasing health outcomes and improving gender equity, there's also the risk that engaging men can compromise women's autonomy or reinforce inequitable power dynamics favoring men. For example, the most commonly cited example of men's engagement in health services is physical support. That is, men's accompanying women to health services. Yet we see in many cases, including examples from global experts, country-level caregivers, and health providers consulted for this evidence review, that sometimes when programs prioritize men's accompaniment, they reinforce this practice by first providing care to couples who attend together at the expense of women who may have been waiting longer yet attend alone. This practice has been shown to be effective at encouraging men's attendance, but it also reinforces social norms that value men's time over women and discourages health-seeking behaviors by women who are unwilling or unable to seek care for themselves or their children, accompanied by their partners. This also neglects women's own preferences, and we see many instances where women do not want their partners to come with them for care. The health center may be a safe space for them and a time to relax away from their partners, and may even provide an opportunity to disclose violence or seek out clandestine contraceptive use. That isn't to say that we shouldn't be engaging men. On the contrary, we know that men's engagement can work. But it does mean that programs designers should consult women about how they want men to be engaged and ensure that program monitoring includes considerations of negative unintended consequences and is equipped to be able to course correct if these negative unintended consequences are identified. Next. So now let's move on to some of our results. Our first learning question was looking at challenges and opportunities to engaging men in child health and immunization. And we saw many challenges identified at all levels of the social ecological model. At the political environment level, our experts noted a lack of policies to support men's engagement, including a lack of social and behavior change strategies that include information provision to men using channels and messaging that resonates with them. At the health systems level, it was noted that health services are often unwelcoming and operating hours conflict with men's working hours. It was also noted by many stakeholders that this lack of engagement with the health system also contributes to misinformation and a lack of correct information and understanding about health services, including immunization. At the community level, all of our stakeholders at all levels mention that social and gender norms around the role of men and women as breadwinners and caregivers, respectively, can impact how men are engaged in health services. Our stakeholders also noted that there are challenges with the men's engagement interventions themselves, in that many interventions at the community level do not work to address these norms, and instead reinforce negative stereotypes and power imbalances. At the interpersonal level, it was noted that while men don't play an active role in caregiving, they are the main decision makers for child health. And as a result, care-seeking behaviors can be negatively impacted if men have negative views about health services, including vaccines. Particularly in Togo, it was noted that marital discord and polygamy can influence men's involvement in child health. If a woman and her husband are not getting along, the men may choose to withhold the ability to seek health services. And in polygamous households, there was a worry that if a man supports one wife and that those children to seek out services, he would then be obligated to do the same for all of his other wives. And all of these issues that we see across the levels of the social ecological model are also indicated at the individual level in terms of how individual men internalize misinformation and socialization around their expected roles in their families. Next. Here you can see a couple of quotes from our focus groups. These are from Togo. The first quote was from one of our women's groups, where they addressed this issue of men as decision maker actually impeding access to health services and in fact sabotaging the mother and her attempts to seek health services. And then in our men's group, it was noted that it really depends on the relationship between the woman and her partner. This quote says, "A disagreement in the home can affect the children, all the while forgetting that it's a child's life that's at stake." Next. Our first question also looked at opportunities, as we can't just focus on challenges. And many of the opportunities listed by our experts, and in some cases by our focus group participants, responded to the challenges that had been previously mentioned. So they talked about development of policies that explicitly lay out how to engage men, as well as orienting key stakeholders and policymakers on how gender impacts immunization and what gender transformative programming looks like. In Pakistan, our stakeholders particularly mentioned that we should be involving other sectors, including education and religious affairs. At the health systems level, opportunities include working with providers to change their own behaviors through training or values clarification activities, as well as other supply side interventions to create a more welcoming environment. And this includes ways of bringing the services closer to the community, including simply extending service hours so that men are more available to accompany their partners. At the community level, it was recommended to engage community leaders, including religious leaders, conducting community dialogues, and using human-centered design strategies to co-create men's engagement interventions with the communities. And in fact, that's what we'll be doing in the next stage of our program. At the interpersonal level, it was discussed that we need to create interventions to focus on true joint decision-making, and which works across generations. And when we think about joint decision-making, we know that right now, men are generally the decision makers and the ones with power in the household. So in fact, joint decision-making doesn't mean giving men a greater role, but in fact, ensuring that both women and men can participate in the decision-making process. And it was recommended that these interventions should also include interventions to increase women's access and control of finances. At the individual level, we talked about correcting misinformation, using sources preferred by men and messaging that resonates with men, and thinking about how our interventions can lead to personal transformation through men's engagement at other levels, including the early engagement of boys and girls to positively transform caregiving norms at an early age. Next. Our second question looked at effective and promising men's engagement interventions. As mentioned, this was predominantly responded to through the literature review. We reviewed there were 20 peer-reviewed studies and 5 documents from the gray literature, which included 8 additional studies. And these results were measured across a variety of child health areas, as well as fathers' child health-related behavior and knowledge. Fathers' behavior changes were measured both quantitatively and qualitatively, depending on the study. And it's important to note that all studies didn't measure father behaviors. All studies did look at different child health outcomes, but in some cases, you may see that there are no results regarding father behavior, and it may be because those studies just didn't look at father behavior as an outcome. So we found political interventions, which included advocacy with health departments on how to integrate gender and men's engagement. And those types of interventions did see positive results with changing fathers' behavior or improving knowledge. At the community level, we saw 2 different types of categories of community interventions. One, which nurtured positive community norms and practices for men's involvement, which including conducting public events in support of men's involvement, or practical activities such as birth planning in the presence of larger groups, which included men and other family members. We also saw strategies to engage community stakeholders, such as religious leaders or traditional leaders, to promote men's involvement in child health. Next. At the interpersonal level, we saw interventions to foster a couple's communication and cooperation through couples counseling, couples discussion groups, in which couples were engaged together or individually. And here we saw positive results with regard to child health. We also saw couples education interventions, which included much of the same content as the previous types of interventions, but was in more of an educational format rather than a dialogue or counseling format. And those demonstrated results in both child health and father's knowledge and behavior. And then we had activities at the individual level. The first was individual communication, in which men were directly targeted through SMS messaging, one-on-one counseling with child health information. And this had results in both child health and father's behavior. We also had individual activities targeting men through group communication, such as multimedia or community sensitizations. And then some interventions looking at practical training targeted only at the male caregiver, which saw some improvements in father's behavior and knowledge. Next. I do want to call out a couple of specific examples within these individual activities. The first is one study looking at individual communication, in which men were targeted directly with information about health, as well as couple dynamics, joint decision-making, etc. So in one of these studies, the study created a cadre of male caregivers, male community health workers, which gave out this information to men. And this study found that men who were reached out to by the male community health workers actually had more engagement with the health system than when the messages were being passed by community health workers, by female community health workers. And this points to another value of this type of intervention, which is that by using men as health workers or as agents of change, that third aspect of male engagement, it can improve supply side interventions or improve the service environment to make it more comfortable for men. Next. I also wanted to call out the intervention that looked at practical training. This was the only study meeting our search criteria with a demonstrated positive outcome regarding immunization. All of the others measured positive outcomes with regard to child health. This study measured an immunization outcome as a secondary measure in a longitudinal controlled study of the implementation of kangaroo care by fathers, in which fathers were trained how to place babies close to their skin shortly after their birth to improve the child's health. In this study, fathers in the implementation group were more likely to take their child to a vaccination service, with 60% of fathers being more likely to exhibit this behavior compared to 17% in the control group. Next. Our third question looked at effective and promising gender transformative interventions. So half of the studies in our literature review that demonstrated positive changes in health outcomes or men's behavioral outcomes included gender transformative interventions. So activities that actively aimed to reduce gender inequality between women and men regarding child health decisions and care. Yet only 2 of these interventions measured gender transformative results. So even though most of these weren't measuring the gender transformative outcomes, it was acknowledged that gender inequality has a negative influence on child health, and these inequality issues did impact child health outcomes. So now I'm going to briefly discuss the 2 interventions that did measure gender transformative results. Next. So the first intervention was in 2012 in Bangladesh. This intervention implemented a community level activity to nurture positive community norms, in which they created safe birth planning in the presence of husbands and larger families. And they also conducted a community activity for engaging community stakeholders to promote men's involvement in child health by recruiting health committees consisting of local elites and engaging religious leaders and village doctors. And here we saw positive health outcomes related to an increased initiation of breastfeeding within 1 hour of birth and improved colostrum feeding, and also a non-significant result of an improved gender transformative outcome of improved joint decision-making at postnatal care. Next. The second intervention that measured gender transformative outcomes was an interpersonal intervention using couples communication. So this intervention conducted responsive parenting interventions for mothers, fathers, and couples. So in addition to engaging the couples together, they also engaged mothers and fathers separately. And fathers-only sessions included content on respectful communication between spouses, resolving conflict, father involvement in childcare, and household tasks and interpersonal support. This study demonstrated a positive health outcome of improved child development, as well as gender transformative outcomes of improved joint decision-making, a positive association between father's interpersonal support to the mother and improved child development, and a positive association between shared decision-making and child development. Next. In addition to the literature review, we also asked our expert contributors through the survey and key informant interviews regarding their experiences with gender transformative health interventions. And so our experts gave us an additional 6 examples of gender transformative interventions which have demonstrated health outcomes. And in 5 of the 6 interventions had also demonstrated gender transformative outcomes. You can see a couple of activities, Bande Barejo and Alive and Thrive, which were evaluated through randomized control trials. The last intervention, Papa Champion, or Champion Fathers, is the only one that did not explicitly measure gender transformative outcomes. However, it, along with the third intervention, Safal Shurat, were the only 2 that demonstrated improvements in vaccine behaviors. It's important to note that Papa Champion is implemented and well respected in Togo, one of our program's implementing countries. And so there's a lot of opportunities to build on this activity and think about how it can become more gender transformative. Next. We do want to spotlight one of these interventions, which were mentioned by our experts, and this is the Bande Barejo, or Program P intervention, created by what is now Equimundo. The intervention is an interpersonal intervention with 9 participatory meetings with trained facilitators for men and 8 additional meetings for men and their partners to participate in together. Topics included critical reflection and dialogue on gender and power, fatherhood, communication, decision-making and healthy relationships, gender-based violence, child health, early childhood development, and men's engagement in various health areas. And they found many positive results with regard to health as well as gender transformative outcomes. Their health results included improved ANC attendance by women, improved FP use for women and men, and decreased physical punishment of children by women and men. They also found many gender transformative results, including a decrease in intimate partner violence, both physical and sexual, an increase in support from male partners during pregnancy, an increase in men's participation in childcare and household work, a decrease in dominance by men in household decision-making, and an increase in men's accompaniment to antenatal care. Next. As part of our evidence review, we also asked our stakeholders about measurement. How are we measuring gender transformative results and men's engagement in immunization? And most of our stakeholders had more questions than answers. Their main questions were, what should we measure to better understand men's engagement in immunization? And how can these measurements be scaled and sustained so that we're not just looking at men's engagement in immunization in the course of studies or projects, but really finding a way to understand the relationship between men's engagement and immunization uptake across regular programming and institutionalizing these measures within immunization programs. So we conducted a review of indicators that have been proposed or that are currently used to measure various dimensions of men's engagement. Many of these come from existing programs funded by donors or from existing studies such as the demographic and health surveys. And these are just some examples of existing indicators. We don't want to be recreating the wheel. There are many indicators that already exist looking at men's engagement in health. And so we've identified some sample indicators based on the various dimensions of men's support or men's involvement in maternal health from the Gal et al. Framework. And so you can see here some examples. And we should also be thinking about process indicators. In addition to looking at these results, we want to be able to measure progress, i.e. changes in men's knowledge, changes in satisfaction, and thinking about the response of men as clients. Next. So where does this leave us? So from this evidence review, as you can see, we gained a lot of insight and a lot of information about the potential role of men in child health and immunization. So we found that global experts, as well as caregivers, indicate that men play an important role in immunization uptake through their role as primary household decision makers, and they identified challenges that exist with regards to men's engagement in immunization programming at all levels of the social ecological model, with a particular focus on social and gender norms around men's roles. Next. We also saw that integrating men's engagement interventions into child health programming can improve child health outcomes and caregivers' knowledge and behavior. However, evidence is limited on the role of men's engagement in immunization outcomes specifically. Next. We've seen evidence from other health areas, including reproductive, maternal, neonatal, child and adolescent health, family planning, and HIV, that demonstrates that men's engagement interventions can not only improve health outcomes, but can also demonstrate gender transformative outcomes. And a limited number of child health interventions that include men's engagement components have tried to measure gender transformative outcomes, and those have demonstrated promising results. Next. Across health areas, we've seen that the majority of interventions having achieved both health and gender transformative outcomes include interpersonal interventions, which target both partners together and/or separately, and include health information paired with content and discussion on couples dynamics and transforming the role of men as partners and caregivers. And I will say that this is the most important type of intervention that we've seen. Many of the interventions that we reviewed were multi-pronged. So they included interventions at various levels of the social ecological model, but almost all of them included an interpersonal component. To a lesser degree, these male engagement interventions also included community level interventions to shift norms around men's involvement in care. And as it was noted by both our experts and our caregivers, is that this is where one of the largest issues exists, and perhaps we should be doing more of this since we know that social norms around men's involvement in care is a huge barrier to more positive involvement in child caregiving and health services for children. We also saw that the two promising interventions mentioned by experts that include only individual level interventions in which only men are targeted, as opposed to both men and their partners, focus on engaging men not only as partners, but also as agents of change, by using them as community educators for gender transformative discussion and health information. Engaging men as agents of change can also address supply side issues around men's comfort in the health system. Next. Our next steps with this evidence review is that we'll be working with our colleagues in Pakistan and Togo to develop country-specific theories of change and men's engagement in immunization frameworks based on this research. We'll be conducting human-centered design workshops in the two countries to develop operations research interventions, and we'll be developing research protocols and submitting to the institutional review boards and country ethics committees to begin implementing those interventions. So hopefully, in another year or so, we'll have a lot more evidence in terms of what works specifically for engaging men in immunization to improve immunization uptake, as well as improving gender equality and gender transformative outcomes. So thank you very much. I'm now going to stop sharing the slides and we'll turn it over to Myra Betron to moderate the Q&A.
Thank you so much, Elizabeth. I think we have a couple of questions already in the chat. Some are clarification, but we do want to open it up for people to ask or pose any questions. Please feel free. You can do so in the Q&A. I think I saw a couple of comments in the chat as well. We can follow up on those. But maybe just to get us started, there was a question by Penny Holding that said, some of the intervention processes listed as not having been peer reviewed have been evaluated and found to be effective. So I guess the question is the idea of peer review too narrow. And I did put in a clarification on our methodology, but did you want to add anything, Elizabeth?
I'm looking at your response here, and just to say that we did acknowledge that many promising interventions have not been peer reviewed, and that is part of the reason why we combined our literature review with our interviews with key stakeholders and specifically asked them for evidence in the gray literature of programs that they were familiar with that may show promising results. So if an intervention had been evaluated internally or in some other way that had not been peer reviewed and it was mentioned by our stakeholders, it was included in the evidence review as a promising practice.
Great. And I think Penny also wanted us to acknowledge that Bandabrejo was actually co-developed with ROMREC as well. Very important to acknowledge that. Thank you, Penny. And we are actually adapting that intervention in other settings, working very closely with the originators. So it's important to acknowledge that. And then there was a question about the availability of the presentation. I just want to confirm, but I do believe we are going to be making these available and also going to be sending the full report once that is finalized in the coming weeks. And then I see another question here from Danielle. Is there a place where we can access the references for each of the articles that were examined during the desk review phase? As I said, the report will be shared, so those citations will be included and the full methodology will be annexed as well. Another question from Angshar. Any finding on the role of religion or culture on the success of men engagement? I think this is definitely a question that comes up often. Do you want to say anything about that, Elizabeth?
Yes, definitely. So thanks very much for that question. So as mentioned, we did see some interventions that were community level to engage community leaders, traditional leaders, other thought leaders in the communities towards shifting men's roles in health areas. And we did see some results with regard to improving child health outcomes, as well as improving fathers' knowledge and behaviors regarding child health. So there definitely is promise of engaging, of using these types of interventions. However, as was noted by our stakeholders, we often see that community level interventions may not be working to transform gender norms, but may in some cases actually reinforce traditional gender norms of the father as the breadwinner, the head of household, the main decision maker. So as we think about how to integrate community interventions, there really is this importance that we think critically about how we're engaging leaders in a way that doesn't do harm and that doesn't reinforce gender inequality and the lack of power for the mother or the woman caregiver.
Thank you. And another follow-up question is, are there any specific studies which include LGBTQI couples? I know we talked about the importance of the diversity of men, so can you comment on that?
Well, within the literature review that we examined, we did not see any studies that specifically looked at LGBTQ couples. Part of this reason is that our inclusion criteria included only low and middle income countries. So it may be that the evidence in these areas are quite limited.
And then another question, which I think is important as well to clarify, from Elsa Berhane. I'm curious how male engagement proved positive in RMNCH and HIV programming, but not immunization.
Definitely, thank you for that question, and it is important to clarify. It isn't that men's engagement has not been or is shown to not be beneficial in child health and immunization. It's just that the evidence base is much more limited. We do have a much stronger body of evidence and research, through peer-reviewed studies, through rigorous programmatic evaluations, looking at how men's engagement has improved health outcomes for HIV and family planning in particular. But part of the reason why we conducted this literature review and this process is that we found that we weren't seeing studies that looked at child health and immunization within the context of men's engagement, coming out with the same level of results. But as we did see, there were many promising interventions and many interventions that didn't measure gender transformative interventions, but that did include gender transformative components. And so we saw that when programs in child health included gender transformative components, that did result in positive health outcomes and positive changes in fathers' behavior. So it looks like there's a very promising possibility of looking at men's engagement and how it impacts both child health and immunization and also gender equality.
Great. And then we have another question. Questions are coming in now. Thank you, everyone. So from Natasha Crowcraft, I really enjoyed the presentation. Thank you. I'm interested to know how you are thinking about approaching the issue of generalizability from specific communities to other settings and cultures. How important do you think it is to conduct research and evaluation in each country in every distinct setting and community?
Thank you. So one of the things we did see through our survey and our key informant interviews, which looked at we looked at global experts. We had, I don't remember the exact number of countries which were represented, but it was a good number of countries that participated in the online survey, as well as the expert interviews. And then keeping in mind that our focus groups were from Togo and Pakistan, which are two drastically diverse countries. Yet many of the responses that we saw were very similar, both in terms of the barriers and opportunities that existed, barriers to engaging men, as well as ways to address these barriers through opportunities, as well as the expert feedback in terms of potential interventions that could work in these contexts. So the first part of the response is that we saw that many of the issues were similar globally and across our two very different country contexts. But the second part of that is we'll be co-creating interventions in Togo and in Pakistan, and with government officials, with other stakeholders, both at the national level, but also in the specific areas, geographic areas where these interventions will take place, because we know there's an importance to ensuring context and ensuring relevance at a very localized level. So we know that the interventions that will be developed in Pakistan and Togo will most likely be very different. And so it's important to look at how these general ideas of what works are adapted to the country context and what kind of results that we see.
Thank you, Elizabeth. And I also wanted to raise another question about the methodology that Penny is asking. which in her words, she says, why do you feel that the biomedical approach to implementation and evaluation that you outlined is more appropriate than processes now favored in implementation literature that is more dynamic, cyclical, and built around shared learning and not expert designed and driven? So can you say a bit about the types of studies we did include in the literature review?
Sure. So again, just to reiterate, we do think there is a value of these peer-reviewed studies and research, but also want to acknowledge that there are other types of evaluation that are equally valuable. And many, of the 6 interventions that were listed by our experts, many of those interventions were evaluated using different means, using process evaluation, using more dynamic and learning and adaptation methodologies. So we did want to ensure that those were included, even though they weren't the types of studies that would have been included in a literature review. And Myra, I don't know if you particularly want to speak about the different types of studies in the literature review or that methodology.
So just to clarify, we did include studies that have both quantitative and qualitative outcomes, not just when we say we included those that included child health outcomes, those were not studies that just measure those outcomes quantitatively. Oftentimes they are, especially the ones that are published in the peer-reviewed literature. But as Elizabeth said, we went beyond and looked at the gray literature as well as consulted experts on interventions that they recommended.
Thank you for bringing up that point, Myra. It is important to note that a good proportion of the studies in the literature review were qualitative studies with qualitative outcomes that came from focus group discussions or other interviews with the programmatic populations. So as Myra mentioned, we will be releasing the full evidence review report. And there you can see a full tabulation of all of the studies that were examined along with their methodologies and how the results were collected.
Maybe it would be good to take this question on gender transformative results from George, a team who asked, could you please clarify if there were any baseline undertaken? Presuming that's the 2 studies that measure gender transformative outcomes.
I don't have the details of the specific studies in mind, but I would assume, given that they are studies that were conducted under the context of randomized control trials, that the results were measured at baseline and endline.
Thank you. And then there's a question here from Tosin Ajayi, apologize if I'm saying your name wrong, who asked, did the literature review reveal any specific countries with opportunities to build on or improve on existing male engagement interventions? In addition, did the review find any national level male engagement interventions? I'm also keen to hear if any of those spotlighted interventions were able to be sustained by government beyond the project period.
Thank you very much. So within the peer-reviewed literature, I believe all of the studies were programmatic studies rather than evaluating interventions that existed at a government level or that were systematically sustained. I will note with that within our interviews with country experts, the government of Pakistan, our experts from Pakistan did note that there is an initiative currently to extend health service delivery hours in the evenings as well as on Saturdays, and they're actually seeing very positive results in terms of increasing men's engagement in bringing accompanying their partners and bringing their children to health services with this intervention of simply extending hours so they go beyond working hours. But I think that was the only example that we saw of a government level intervention that was being sustained. And Myra, I think you can speak to Bande Barejo, which is one of our industry's great examples of a program where the results are continued beyond the end of the project.
Yes, I think it sounds like a number of people on this webinar are quite familiar with that intervention, but that is an intervention that is being scaled up alongside by the Ministry of Health and Ramwek in Rwanda. And they were engaged from the beginning. So that was definitely a very important approach. Do we want to say anything about Papa Champions and how that is implemented?
We can. So Papa Champion, or Champion Fathers, is an intervention in Togo in which men are trained as community leaders. I mean, they're trained not only in vaccination and health information, but also in leadership skills, negotiation skills, facilitation skills. And the Papa Champions, once they're trained, they work together as a group and develop strategies for how to best engage men in their communities, either through community level sensitizations or one-on-one household visits. And this program is very, very well known in Togo, very well respected, and has shown great results in terms of increasing immunization uptake through this work of engaging directly with fathers. So this is an individual level intervention in which fathers are engaged, but the female partners are not engaged. Papa Champions has not measured gender transformative interventions in terms of how men's attitudes are changing or couple dynamics are changing. But looking at this intervention and the positive results that have been seen with regard to immunization, and particularly given that one of our target countries is Togo, there is certainly the possibility of working with our collaborators in Togo to think about how this intervention could be scaled up or potentially adapted to include a gender transformative component.
Thanks, Elizabeth. I was just thinking about whether the government is quite involved in that one as
Oh,
well.
yes, absolutely. Thank you.
Great. And then we have another question here from Christopher Kangpatinge. Yeah, I'm not sure if I said that correctly, but were there geographical considerations in selecting the study subjects such that findings or views of the respondents can be generalized? I mean, we looked at various studies, so I'm not sure if this question is looking at or asking us to comment on all the studies or just one study.
Yes, let me reshare the slide regarding the methodology. Sorry, as I slide back across the whole presentation. So just to note that within the literature review, we did have studies from 19 countries, Asia, Africa, and South America. And then our online survey included respondents from Africa, Asia, Europe, Latin America, the Caribbean, and North America. Our key informant interviews were global experts, as well as some regional West Africa experts, as well as our experts in Togo and Pakistan. So in terms of the expert level and the literature review, we had quite a diverse geographic distribution. And as mentioned, many of the types of interventions that we saw were quite similar across the different geographic areas, and many of the types of results that we saw in terms of, and particularly in terms of whether the type of intervention was effective at meeting child health results and father's behavior results were also very similar. So in that sense, we could see that there was some generalizability among the effectiveness of certain types of men's engagement strategies on child health and on father's behavior. And once we do release the full report, you will be able to see the various studies in greater detail, including the countries of implementation.
Great. And just time for one or two more here. There was an important question about whether the 5 male engagement indicators constitute a minimum package.
Thank you for that question. And I certainly want to clarify that those indicators are not our recommendation of a package of indicators to be used for men's engagement interventions. At this stage, they are completely illustrative. Looking at the large bank of indicators that we reviewed upwards probably of 80 indicators. Many of these had already been defined by the Equity Reference Group for immunization, looking at how to measure gender across a variety of dimensions for immunization. So based on the indicators that already exist, based on what different programs are doing to look at men's engagement in immunization, we mentioned some indicators that could potentially be used to measure these different dimensions of men's engagement. However, as part of the work that we will be doing going forward in Pakistan and Togo, we will be developing a monitoring, evaluation, and learning framework as part of the operations research development. And as part of that, we will be proposing certain indicators that are most relevant for our country context to measure the results of the operations research. So one outcome of this operations research may be to provide a more formalized list of indicators, which really can be used for different types of interventions to measure men's engagement outcomes.
Thank you for that clarification, Elizabeth. And then another question along the lines of clarifying what were the criteria that we used to choose Togo and Pakistan for this pilot phase?
Trying to remember, it was quite a long time ago that we developed the program proposal. I mean, part of it was looking in areas in which we as Jhpiego were currently working where we had experience and relationships with immunization programming. And we also were looking at countries and areas that had a high level of zero-dose children. You know, we did want to ensure we were working in areas that would have the largest impact with regard to these types of programming, and also areas where the number of zero-dose children and access to immunization services was not tied to vaccine availability. Since these interventions will not be related to commodities, they'll be related to men's engagement. And so if we were working in areas where vaccines were not available, it's unlikely that we'd see any type of results. I don't know if you want to add anything, Myra.
Yes, certainly zero-dose communities or countries, high levels of zero-dose, or the priority countries for zero-dose were very much how we considered that. And of course, where there were some strong immunization programs we wanted to build off, that was something that we discussed with Gavi. But speaking of which, I do want to turn it back over to Jean. She might want to also comment on this and talk about some of the next steps for this work.
Great, thank you very much, Myra, and thank you to Elizabeth. As we've seen in the chat, I think there's a real appreciation for this review. Pulling together all the literature is one step, but going through it and showing such a strong analysis has been really useful. I'm really excited to see so many people, so many of our partners on the call with us. And just to underscore, we really want these types of interventions in our health system strengthening grants. And this literature review is just showing us a little bit more of the nuances of how really to implement so that we get the positive results on health outcomes as well as equity. I would like to first start by thanking the Jhpiego team, both in headquarters, the Togo team, the Pakistan team, for conducting such a rigorous review. To thank all the facilitators of the research for the focus group discussions and the key informant interviews. To thank those who were interviewed, all the experts in this area, and to thank those who've been part of the literature review process so far. So in terms of next steps, the two teams will now start to design in Togo and Pakistan different interventions that can be tested. Then they'll be implemented and evaluated. So we'll get more results on the effectiveness of the different types of approaches that we've just been talking about. We really look forward to seeing those results. In terms of the report, I think we'll be able to send it out to all those who've registered. So we have all of your emails, so you'll get the report as well as the presentations. And we'll also be putting it on the Gavi Secretariat website. If you want to look under the gender and immunization page, we'll have the report there available to download. So huge thank you to the Jhpiego team. And Elizabeth, I'll pass it back to you for some final words. Thank you.
Thank you very much, Jean. So thank you everyone for your participation today, as well as for your insightful questions and participation in the chat. As Jean mentioned, we'll be sending out the presentations as well as the recordings in the 3 languages, and then shortly after that, the full report for your review. And we look forward to sharing with you the next steps in the program and the results of our implementation research activities in Pakistan and Togo. So thank you and have a great morning, afternoon, or evening.
Thanks, everyone.